From the Journal of Nuclear Cardiology, this is JNC Cardio Connect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Welcome, everyone, to another episode of JNC Cardio Connect, the official podcast of the Journal of Nuclear Cardiology. I am Marcelo Di Carli, the editor-in-chief, and I'm delighted to welcome you to a special episode that we are dedicating to our upcoming compendium on cardiac amyloidosis. Cardiac amyloidosis has undergone a remarkable transformation over the past decade, from mostly a rare disease that was frequently overlooked and a condition that leads to increasingly recognized and treatable cause of heart failure. We know that advances in our understanding of disease biology, the emergence of new diagnostic strategies, and the arrival, most importantly, of effective therapies have fundamentally changed how we identify and care for these patients. We have recently completed a compendium that brings together some of the foremost experts in the field to help us synthesize all the developments across pathophysiology, imaging, and novel therapeutics. So I'm really honored today to be joined by four of the contributors to this compendium. Dr. Omar Abu Ezzeddine, a heart failure and amyloidosis specialist at the Mayo Clinic. Dr. Prem Soman, Director of Nuclear Cardiology and Associate Chief of Cardiology at University of Pittsburgh. Dr. Sharbira Dorbala, Director of Nuclear Cardiology at the Brigham and Women's Hospital. And Dr. Ahmad Masri, a cardiomyopathy and amyloidosis specialist at Oregon Health and Science University. Welcome to all of you. I'm looking forward to our conversation, and thank you in advance for your time. The compendium begins with telling the story of the pathophysiology of this disease, which has been fascinating. And Omar, we'll go first to you. You're one of the authors of that manuscript. So what are the most important novel insights that clinicians and imagers alike should take away, and how do you think they inform what we see on imaging and the implications that we see clinically?
Thank you, Dr. Di Carli, and congratulations on this beautiful effort. In our section of the compendium, we highlight how we currently think of cardiac amyloidosis and explain why imaging behaves differently across subtypes, and that really has direct clinical implications. The first major takeaway is that ATTR and AL cardiac amyloidosis are fundamentally different biologic diseases. Even though both may produce increased wall thickness and restrictive physiology, in ATTR, the dominant process is progressive extracellular fibril deposition. And so the myocardium gradually becomes infiltrated and stiff because of ongoing TTR fibril accumulation. In contrast, light chain amyloid is not just an infiltrative disease, but it's also more of a toxic cardiomyopathy, whereby circulating light chains directly injure cardiomyocytes through oxidative stress, mitochondrial dysfunction, inflammatory signalings, and ultimately impaired autophagy. And this distinction really helps explain several imaging observations that we see clinically every day. For example, TTR patients often have very impressive wall thickening, marked extracellular expansion on MRI, for example, classical apical sparing patterns on strain imaging, and strong uptake on bone avid scintigraphy. That fits with a disease driven largely by accumulation of these amyloid fibrils in the extracellular space. AL is different, whereby patients can look dramatically sicker than their echo does typically, despite having less total amyloid burden perhaps. On imaging, they may have less hypertrophy, but much more higher elevation in biomarkers of myocardial necrosis, more edema on CMR, and rapid clinical deterioration because of this cardiotoxicity. So imaging isn't just showing infiltration, but it's also reflecting some form of active myocardial injury. The second key insight I'd like to highlight is that imaging signals are actually telling us something about the microenvironment of amyloid, not simply about the type of amyloid that's present. For example, bone scintigraphy with PYP or HMDP currently and DPD across the pond appears strongly linked with TTR fibrobiology associated, what we think, microcalcifications, where TTR, especially the wild type form, tends to have more membrane bound microcalcs, which may explain the avid tracer uptake. Meanwhile, light chain amyloid has less microcalcs and perhaps more of an inflammatory milieu, so uptake is often absent or weaker. Although importantly, some AL patients do have significant uptake, which is why monoclonal protein testing remains essential. The PET story, which I'd love to hear from Dr. Dorbala about, is also very fascinating because different tracers interrogate different biologies. The PET tracers like florbeta-peer and florbeta-pen, and now more recently, we're very excited about evuzametide. It binds the actual amyloid fibril directly and can detect multiple amyloid subtypes. So clinically, the broader implication is that imaging is moving or evolving, if you want, from purely a diagnostic tool into a biologic biomarker. We're moving beyond simply asking, is amyloid present, to asking what subtype is this, how active it is there inflammation, remodeling, or a regression, more importantly, with therapy. And that's particularly important as therapies evolve from stabilization and silencing to amyloid clearing strategies, where serial imaging may ultimately become the best way to monitor tissue level response, for example.
Fascinating, Omar. Thank you so much. It was really a joy to read that initial chapter. Prem, we're now going to you. You're both an imager and also an amyloid specialist. And the question for you will be, okay, in nuclear cardiology, our workhorse is bone avid cardiac scintigraphy for the evaluation of these patients. Could you please give us a description of what are the current best practices? How do we do patient selection? What are the highlights of acquisition protocols and interpretation? And what are the things that we shouldn't be doing? And could you also please highlight some of the pitfalls that we still need to deal with bone avid cardiac scintigraphy?
Marcelo, thank you for having me. And it's such a pleasure to be here with you and the rest of the panel. The most important thing, or the first important thing to remember, Marcelo, is that not all bone-seeking tracers have a high sensitivity for the detection of amyloidosis. This is an important point because the most widely used bone-seeking tracer, technetium MDP, does not have a sufficient sensitivity for the diagnosis of amyloid and should not be used. And there are several case reports in the literature of the diagnosis being missed because the wrong tracer was used. So as Omar briefly alluded to, the right tracers in the US are pyrophosphate or HMDP, which is also called HDP, and across the pond it's DPD. These are the only diphosphonate bone-seeking tracers that must be used. Like any imaging test, the optimum diagnostic performance is obtained when the test is applied in the right clinical context to the right patients. This is true for amyloid. For diagnostic testing, that today is a symptomatic patient with heart failure and something else that's suggestive of amyloid, like unexplained left ventricular hypertrophy or multiple red flag symptoms for amyloid. Now, I will say that as our understanding of the disease and the populations expand, we do apply it sometimes in other contexts, but routinely for diagnostic screening, this is the population that most benefits from the application of this test. Now, in 2026, SPECT is mandatory. One simply should not make a diagnosis of amyloid based either on planar perigeny scoring or a heart to contralateral ratio. That would be bad practice today. It is absolutely important to have SPECT. Now, there has been considerable debate about the optimal timing of imaging after injection. Now that we're all routinely using SPECT, which means we can accurately localize the tracer to the myocardium and distinguish tracer in the blood pool, most of us are moving towards earlier imaging. I think it's reasonable to start imaging at 1 hour. I think with the application of SPECT in most patients, we can make a diagnosis. The caveat being, if you still see a lot of blood pool, you will have to repeat the imaging at 3 hours. Now, the optimal timing also depends somewhat on the different tracer kinetics. And for HMDP, I would say that 1 hour imaging is mandatory because of the distribution kinetics that are a little different. And with later imaging, it does seem that there is a possibility of the myocardial signal being weaker and a drop in sensitivity. There's some very interesting work from Brett Sperry's group recently supporting this notion. So 1 hour imaging is optimal for HMDP, and I think could be done for PYP also, with the possibility that in a small proportion of patients, we might need to repeat imaging at 3 hours if there is blood pool. Now, the interpretation should be done in the context of serum studies. We all know this to exclude AL amyloidosis. From a pragmatic standpoint, we don't always have the serum studies when we report the PYP or HMDP scans in our lab. We have a qualifying statement to say that serum studies should always be performed and the interpretation made in the context of those results. And finally, a basic tenet of all imaging studies, if there's a discordance between what you think clinically and imaging, we should always do that additional step of trying to clarify that discordance. And in the amyloid context, it's usually an endomyocardial biopsy. In our center, we do biopsies in maybe 15 to 20% of patients to get a confirmed diagnosis. Amyloid scintigraphy has, as you said, been transformative for the field. And when one follows all these steps, it is a remarkable test with diagnostic accuracies we rarely see in imaging.
Thank you, Prem. Great summary and a lot of important clinical and teaching points, as always. Ahmad, we're going to you now. You're a clinician, you're an expert in amyloid, but you also have expertise in other forms of cardiomyopathy, including hypertrophic cardiomyopathy. And although cardiac scintigraphy obviously is an important element of the diagnosis, we also use other imaging modalities, i.e. echo, MRI. Tell us a little bit of your approach. How do you integrate these other imaging modalities in your diagnostic or management algorithms when you see these patients?
Thank you, Marcelo, and happy to be here. That's a great question. I think part of the story is to remember that amyloid, while the red flags allow us to suspect a potential diagnosis, there is not a singular thing that you can find clinically that will actually confirm such a diagnosis. And as such, you really highly rely on imaging. And the way that the bone tracers have been studied, as well as logically how they would likely perform, is that they are to confirm a diagnosis. And as such, that's where we come with the echocardiography as our first line test to, after EKG, to look at what is going on at the myocardial level, at the myocardial structure. If I suspect amyloid, am I finding enough imaging evidence that could mean that someone has amyloidosis? Obviously, there are always exceptions, but that's kind of a clinical scenario. And echocardiography suffers a little bit from lack of specificity. So let's assume a population of LVH coming for an evaluation of heart failure. If it's advanced enough, you should be able to pick on amyloid on the echo, but the reality is most of these patients follow the bell curve and they will be right in the middle. It's not going to be too advanced, especially nowadays. And so on echo, you see left ventricular hypertrophy, you see some tissue diastology, being abnormal here or there. But EF used to be thought that it has to be low. It's not. We have patients with hypercontractile ventricles having amyloidosis as well. If you have women, for example, they're not going to have severe hypertrophy as well as much as men do. So you have to keep a high index of suspicion. If the echo is really clearly making you suspect amyloid, I think you should just jump to ruling out AL and doing bone scintigraphy with either HTP or PYP in the United States. If you are not sure and you have someone with LVH or heart failure, and it's not very clear slam dunk that this is amyloid, I think you should go to intermediate test, which is cardiac MRI. The cardiac MRI can evaluate, again, structure and function, but also will give you the chance of using different mapping techniques as well as late gadolinium enhancement patterns to allow you to really refine your risk and refine your pre-test probability. If that shows you suspicion for amyloid, then you continue down that same path. If that shows you suspicion for a different disease, then you could go to that, other disease. I think these are all useful. I don't think one of them will be the arbitrator. But this is a good segue for the next discussion, where I think where we need to be in amyloid in the future is try to simplify this over-reliance on the clinical story, the clinical picture, and multiple imaging tests to allow us to come more upstream. If I think that an elderly patient could have amyloid, I want to try to go after that directly without having to synthesize all of these different variables and lots of information from different tests.
Great master clinician view of how to integrate this and how complicated this is in some scenarios. So thank you, Ahmad. Sharmila, we're going to you now, and you've done a lot of great work, and you're probably leading the space on PET, but you've also done some work on quantification. And we heard from Prem how we do now our clinical work. And I would like for you to comment on where do you think quantification will fit into our SPECT world, but also give us a summary of where do you think the PET field stands today and where do you think we're moving with the novel amyloid targeted tracers.
Thank you so much, Marcelo. It's really exciting to join this esteemed panel on the discussion about amyloidosis and radiotracer imaging, which is, of course, one of my pet topics to discuss. As we just heard from Dr. Prem Soman, and as we all know, current clinical practice with SPECT primarily relies on visual interpretation. We look at myocardial uptake, look at bone uptake, make a comparison, and report visual grading. But with recent advances in SPECT technology, quantitative imaging is becoming much more feasible in routine clinical practice. And this advance of quantitation could really move the field beyond just a simple diagnosis towards something more precise, like assessment of disease burden, risk assessment, and assessment of treatment response. Having said that, some questions still remain with SPECT cardiac radionuclide imaging. And most importantly, this is because we really don't understand the biological mechanism of why these tracers, the bone avid tracers, are taken up in the heart. So that's where I think we can link to the next major advance in development, which is the emergence of amyloid binding PET tracers. So unlike the traditional bone avid SPECT tracers, amyloid binding PET tracers, as we know, bind directly to amyloid fibrils, potentially making them much more specific for detecting amyloid deposition. And PET imaging, as this audience is familiar with, is inherently much more quantitative than SPECT. And these amyloid binding PET tracers can detect multiple subtypes of amyloid, can detect amyloid in multiple organs. And this really greatly expands their role both for diagnosis and disease monitoring for a systemic disease like amyloidosis, where it's not just the heart, but multiple other organs can be affected. So one of the most exciting examples that we've heard most recently about is I-124 evozamitide. This is a radio-labeled synthetic peptide which targets the heparin sulfate proteoglycans found in all forms of amyloid fibrils. And this tracer is really exciting now because last week we just heard that this tracer met the co-primary endpoints in a phase 3 multi-center clinical trial looking at diagnostic efficacy of this agent to detect cardiac amyloidosis. So this tracer, if approved, could really become the first single test that can diagnose amyloid or exclude cardiac amyloid, regardless of the precursor protein. So coming back to the point that Dr. Ahmed Masri was talking about, we currently use multiple different tests, clinical suspicion followed by echo, MRI, laboratory testing, and maybe finally bone avid tracer scintigraphy, and if negative, biopsy, as mentioned by Prem. It's possible, based on how the results turn out, that an amyloid binding PET tracer, which is highly sensitive and specific, could potentially become a single test. You just suspect amyloid, do this test. If it's positive, it's amyloid, then you, of course, do whatever else is necessary. If it's negative, move on to a different evaluation. Find out one of these other causes of thick ventricles or symptoms that these patients may be suffering from. So I think in this regard, this is really exciting. Then, of course, PET tracer, being quantitative, can identify severity of the disease process, can potentially detect early disease, identify systemic organ involvement, reduce the need for invasive biopsies, and hopefully improve assessment of disease progression and treatment response. In this regard, there were other tracers as well studied with PET. We had some experience with F18 floor beta pair in AL cardiac amyloidosis, and a similar tracer called floor beta Ben. So F18 floor beta pain has also recently completed a phase 3 trial, and we are looking forward to the trial results. So all in all, I think advances in PET amyloid imaging hopefully will fundamentally reshape this disease and this field on how we diagnose it, how we phenotype this disease, and how we monitor disease progression and treatment response in the years ahead.
Thank you, Sharmila. I think truly this is a reminder of how exciting the field of molecular imaging has become. And I think amyloid is the poster child for that, where we had struggled for years to find how molecular imaging will actually change diagnosis or management. And I think we finally found the key demonstration of a disease where this will play such a big role. So now, building on all these exciting developments, I'm always wondering about what will be the role of imaging, or will there be a role for imaging in monitoring disease or assessing treatment response, or even guiding how we would use the different therapies available. So Omar, Prem, and Ahmed, if you could give us a succinct view whether you see this as a possibility in the future that will be clinically relevant outside of research, and what would it take to get there? Omar, we'll start with you. We'll go to Prem, and then we'll go to Ahmed.
So as you mentioned, one of the most exciting shifts in cardiac amyloid now is moving beyond diagnosis to therapeutic response and monitoring what happens to the biology. We're still in a transitional phase, but there's a lot of opportunity. Traditionally, we've monitored patients' symptoms, biomarkers like natriuretic peptides and components, functional capacity, etc. Those remain essential, but they're still indirect measures. And so, the question is, what really offers that direct window into the actual amyloid burden and tissue remodeling? And I think, as Dr. Dorbala very eloquently stated, the clearest opportunity, in my opinion, is within nuclear imaging is PET tracers, because they really give you that direct sort of insight into the microenvironment, into the amyloid burden itself. And so I think that's much more promising for treatment monitoring compared to cardiac or bone scintigraphy, particularly agents like uvazamotide, for example, as was mentioned. Now, CMR may also have an important role, I think. Extracellular volume mapping gives us a quantitative measure of myocardial infiltration. And there are now a few studies that have highlighted that, changes in ECV with successful therapy are informative. But again, we still lack standardized thresholds defining what really constitutes a clinically meaningful imaging response. And I think that's really the remaining gap. And that's the next frontier, is standardization of our protocols and validation on what really is truly a successful imaging endpoint or treatment response. And I think the field is, as you mentioned, really heading towards multimodality precision imaging. And I think that's going to be really critical as we enter the era of amyloid clearing therapeutics.
Rem, your thoughts?
That was a very nice summary by Omar. I don't know that I have much to add. I think one of the challenges with creating good imaging protocols to monitor diseases a lack of good understanding of the pathobiology of treated amyloidosis. For example, we don't quite know what happens in the myocardium when you treat amyloidosis. Is it a reduction in the toxic component that is primarily responsible for the dramatic change in patient prognosis and symptoms, or is it the actual removal of amyloid? And when you don't know what's happening, it's difficult to figure out what to image. But the development in PET tracers is remarkable because it is the only imaging modality at this time that directly binds to amyloid. Everything else is a surrogate marker of the effects of infiltration. And in that respect, it's very exciting. But Marcelo, I will also add that, the beauty of pyrophosphate scintigraphy is its simplicity. That is available everywhere. And it can be applied to such a broad population, irrespective of body habitus, atrial fibrillation, renal dysfunction, contrast allergy, implanted devices. And so I think for the near future, for screening large swaths of the population, it's a remarkable screening test. Yes, if the sensitivity had been even better, that would have been great. But from a pragmatic standpoint, I think we're going to be left with bone-seeking tracers in the near future for screening. But for disease monitoring and for further characterization of what's happening in the myocardium, the advances in the other fields are really exciting.
Ahmad, you're leading many clinical trials in amyloid and outside of amyloid. And I wonder, do you think there will be a future where you as a clinician will use this to decide a patient is not responding, I need to consider a different therapy? Do you see that future is possible?
Yeah, we have to. I don't think we actually have an alternative. I mean, the current therapies are not, for example, at least as we are approaching them, such as monoclonal antibody-based therapies for removal of amyloid. It's not a simple therapy. It's, infusions frequently, every 2 weeks, every 4 weeks. Let's say in the future it becomes every 2 to 3 months. But, we'll see what the clinical trials show. The bare minimum we have to see is that there are improvement in outcomes. But once you have improvement in outcomes, for every 100 patient that comes through, lots of them might say, no, I don't want to go through this. Or lots of them might say, well, how do I know if the treatment is working? I'm not going to wait until I die to know if it's working or not. And so I don't think we actually have an out of this. And it is on us to try and figure it out, which, lots of initiatives are ongoing. All of the panel have highlighted them, so I'm not going to repeat them. But I think the principle is we have to. There is no way around it, and we need to figure out a specific modality. We can sacrifice sensitivity when it comes to change and monitoring of treatment, but we need a specific modality, and that's where, lots of the new work is going.
Fantastic. And so now we move to the last block, and I'm going to give you 1 minute to each of you. And what I would like you to do is to give us, what do you think would be the single advancement or innovation that you believe will be most transformative in the near future, say 3 to 5 years? It could be diagnostic, therapeutics, or both. We'll go Sharmila first, and then we move on.
Thank you, Marcelo. So I will probably touch upon the diagnostic aspect of it as a single advance or innovation. So as we all know, we currently rely on symptoms or changes in structure and function of the heart and various organs to diagnose amyloid infiltration. So I believe the most transformative advance over the next few years will be to really detect preclinical amyloid deposition, identifying disease before there's any meaningful change in cardiac structure or function, And this is not screening, but this is more along the lines of active ascertainment of disease in individuals at risk. And I believe this is really transformative because this earlier detection could fundamentally change how we treat these patients. It opens the door to individualized treatment strategies, which is you see amyloid, then make a decision whether or not to treat them. And this opens a possibility of preventing symptomatic cardiac amyloidosis and preventing irreversible disease. So I think that preclinical disease detection is likely going to be the most important innovation, and PET tracers probably will be getting us there.
Wonderful. Ahmad, you're next.
So, there's a lot happening. If I can summarize them in three quick buckets, one is I totally agree with Dr. Durbala that I think PET tracers, are going to be transformative, and we have to put in the work to show that. The second piece is that we do need a biomarker for amyloid, for transthyretin amyloidosis specifically, in order to expand at least the ability to identify at-risk individuals, not to diagnose, but at least to identify these individuals. So a circulating biomarker, I think we're really in dire need for that. And then the third thing is what's happening already, that we need to be able to improve patients from baseline. Right now, on average, we don't. And so we want to be able to improve patients from baseline. I think these three buckets are going to be, at least in the next 5 to 10 years, the goals that we have to go after.
Fantastic. Prem, you're next.
Well, Marcelo, some years ago, there was a case report from the Royal Free, the National Amyloidosis Center. And it was a case report in 3 or 4 amyloid patients who developed spontaneous antibodies towards amyloid, which completely cured the disease. All the therapies we have now are therapies that delay disease progression. We don't have a cure in sight. So the ultimate therapy, which I think the 3 to 5 year horizon that you gave us is probably a little too short for this, but the ultimate therapy would be if you can induce our own bodies to produce some antibodies against amyloid and then cure the disease, that would be remarkable.
Great. Omar, bring it home.
If I have to pick a single advancement, I agree with all that's been said, obviously, but I'm going to put a plug-in for therapeutics. It'd be a transition from disease stabilization to true amyloid clearance, especially with these antibody-based therapies, combined with our precision imaging, as was mentioned. And what makes this especially transformative, in my opinion, is that imaging is moving in parallel with this, as was mentioned today. Molecular imaging, particularly PET and quantitative nuclear imaging, may allow us to finally measure this tissue-level regression in vivo rather than inferring response indirectly from symptoms or biomarkers. So I think we're moving completely towards a new treatment paradigm, as Dr. Dorbella mentioned earlier, detection. But I do believe also that biologically targeted therapy and serial imaging guided management is the way forward, not just keeping patients stable, but also potentially achieving meaningful recovery.
Well, thank the 4 of you for this incredibly enriching and forward-looking conversation. This has been a real treat. For our audience, I want to remind you that this is just the appetizer, what you just heard. You can take a deep dive into the JNC Compendium, which offers all of the things you heard, but in greater detail and with a lot of references for you to educate yourself more about the different aspects of the disease. The full compendium is available from the JNC website and is free for all. It's open access through a very generous grant supported by AstraZeneca. So again, I encourage you to pick up the supplement and take a deeper dive. Hopefully for the young generation, you'll find it inspirational, that will take you to want to do research and engage with these amazing leaders that you just heard on their own programs and future research. Thank you very much for listening, and until the next episode.